So this is part 3 of the neurologic disorders. So let's talk about stroke. This is a cerebrovascular accident. It is an abnormal condition of the blood vessels of the brain characterized by hemorrhage, embolus, or thrombus. African Americans have a high mortality rate, so they're more prone to getting strokes. And strokes are classified as either ischemic or hemorrhagic. So factors that contribute to strokes are hypertension, high cholesterol, smoking, low dose oral contraceptives, atherosclerosis, and diabetes. So for your ischemic stroke, you have the thrombotic and the embolic stroke. So in the thrombotic stroke, this is the most common cause of stroke due to narrowing of the artery by fatty deposits called plaque. It's most often seen in 60 to 90-year-old age group. And thrombotic strokes have been preceded by a TIA. So the symptoms tend to occur during sleep or soon after arising. For your embolic stroke, it is the second most common cause of stroke. People are usually younger, and the embolus travels upward to the cerebral circulation and lodges where a vessel narrows or bifurcates. It lodges and blocks the flow of blood. Then you have your hemorrhagic stroke. It results from bleeding into the brain tissue or subarachnoid space. An aneurysm is often the cause of hemorrhage. It has no forewarning. Like in the other ones, they had the TIA. So this one has no warning. And 50% of patients die soon after the stroke. So your TIA. This is temporary episodes of neurologic dysfunction. It may be caused by microemboli that temporarily occlude the blood flow or by the narrowing of small vessels in the brain. You'll have contralateral weakness of the lower face, hands, arms, and legs, transient dysphagia, numbness or loss of sensation, temporary loss of vision of one eye, or sudden inability to speak. A TIA should be considered a forerunner of stroke, and the patient is given medication that prevents platelet aggregation, such as aspirin or Plavix. So you're going to assess for numbness, tingling, headache, change in level of consciousness, hemiparesis or hemiplegia. A lesion on one side of the brain affects motor function on the opposite, which is contralateral, so the opposite side of the body. So in right-handed people and most left-handed people, the left hemisphere is dominant for language. So when the stroke damages the dominant hemisphere of the brain, which we just said is the left side, left hemisphere, the patient may experience aphasia, which is a total loss of comprehension and use of language. A stroke affecting Broca's area results in the person having difficulty with the ability to articulate words. So this is expressive aphasia, but the ability to make vocal sounds and to understand written and spoken words remain intact. In receptive aphasia, it results when the stroke damages the Wernicke's area and patients have difficulty comprehending spoken word and written communication. They may also have dysarthria, which is difficult or poorly articulated speech. For your diagnostic tests, they can do CT, MRI, EEG, or a PET. Medical management, so you can give the TPA within 3 hours. This is the drug. Or you can do the surgery, which is the embololectomy, and that's performed within 8 hours. They can give anticoagulants such as heparin, Lovenox, or warfarin. Platelet inhibitors such as aspirin and Plavix, and drugs used to reduce ICP are dexamethasone, so that's your corticosteroid. Suppositories to prevent straining such as Dulcolax, and fluids may be restricted the first few days. Your nursing interventions. You want to monitor their neurologic status. You can use the Glasgow Coma Scale. You can monitor their LLC, pupillary responses. Tube feedings and IV fluids may be necessary. Teach one-handed dressing techniques. Foley catheter may be inserted. Patient may experience loss of proprioception. Unilateral neglect may occur. Speech problems may exist, and you want to remember to act fast. That's face, arm, speech, and time. So notice facial drooping, one-sided weakness, garbled speech, and then call 911. Next, we have trigeminal neuralgia. This is caused by degeneration of or pressure on the trigeminal nerve, which is cranial nerve 5, and its etiology is unknown. It is also called tic douloureux. It usually affects people in middle or late adulthood and is slightly more common in women. So clinical manifestations, they're going to describe excruciating, knife-like or lightning-like sock in the lips, upper or lower gums, cheek, forehead, or on one side of the nose. The pain radiates along one or more of the 3 divisions of the 5th cranial nerve, and the pain typically extends only to the midline of the face and head. The attack lasts 2 to 3 minutes and are generally unilateral, so one-sided. Areas along the course of the nerve are known as trigger points, and the slightest stimulation may initiate pain. So such things as chewing, brushing your teeth, hot or cold blasts of air on the face, washing the face, yawning, or even talking. Medical management, you can give anti-seizure medications, you can give gabapentin for nerve pain, muscle relaxants such as baclofen. Absolute alcohol may be injected into the peripheral branches of the trigeminal nerve. And so your nursing interventions, note that the patient may be undernourished. They may not have washed or shaved or combed their hair for some time. Oral hygiene often has been neglected. You want to provide comfort measures and ensure that food is lukewarm because they're sensitive to extreme colds and heat. Next, we have Bell's palsy. It is thought to be caused by an inflammatory process involving the facial nerve, cranial nerve 7. And although the exact etiology is not known, there is evidence that reactivated herpes simplex virus may be involved in majority of cases. Disorder can be unilateral or bilateral. Clinical manifestations are abrupt onset of numbness, stiffness, or drawing sensation of the face. Unilateral weakness or the facial muscles usually occur, resulting in a flaccidity of the affected side of the face, with inability to wrinkle the forehead, close the eyelid, pucker their lips, smile, frown, whistle, or retract the mouth on that side. And the face appears asymmetric with drooping of the mouth and cheek. So you can give corticosteroids, you can give acyclovir. Your nursing interventions are to protect the eye when the eyelid does not close. So you can do the eye shields at night. Artificial tears may be ordered. You can massage the affected areas, and active facial exercises may be prescribed for 5 minutes, 3 times a day. And that's going to be wrinkling the brow and the forehead, closing the eyes, and puffing out the cheeks. Next, we have Guillain-Barré syndrome. It is an acute, rapidly progressing, and potentially fatal form of polyneuritis. It results in widespread inflammation and demyelination of the peripheral nervous system. The etiology is unknown, but it is thought that an autoimmune reaction following a respiratory or GI viral infection. So in GBS, the antibodies attack the Schwann cells, causing the sheath to break down, and the uninsulated portion of the nerve becomes inflamed. Nerve conduction is interrupted, causing the classic sign of muscle weakness, tingling, and numbness. These signs begin in the legs or feet and work their way upward. When remyelination occurs in reverse, it starts at the top of the body and proceeds downward. So they're going to have this paralysis starting from their feet, moving up to their legs, and then when the remyelination occurs, it's going to go in reverse, so it'll start from, so it's going to heal from the top to the bottom. So your clinical manifestations, again, the paralysis starts in the lower extremities and moves upward to include the thorax, upper extremities, and face. Respiratory failure may occur if the intercostal muscles are affected. Fluctuating blood pressure may occur as a result of effects on the autonomic nervous system, and they can do a CT scan or lumbar puncture. Medical management, typically requires hospitalization. They can give some steroids. Patients who develop respiratory failure require mechanical ventilation and may require a tracheostomy. Your nursing interventions are to monitor respiratory function, note that cognition is not impaired, monitor for signs of hypoxia, and assess vital signs. Next, we have meningitis. This is an acute infection of the meninges, often caused by bacteria. The bacteria cause an inflammatory reaction in the pia mater with pus accumulation in the arachnoid space, high protein and white blood cell levels in the CSF, and possible injury to the nervous tissue. So meningitis is classified as bacterial or viral, and the incidence of meningitis is higher in fall and winter when upper respiratory tract infections are common. So you have your clinical manifestations, you have the Kernick sign. This is the inability to extend the legs completely without pain. You have the Brudinsky sign, which is flexion of the hip and knee when the neck is flexed. The onset of meningitis is usually sudden and characterized by severe headache, stiffness of the neck, irritability, malaise, and restlessness. So here's your picture here. They're going to have pain in the leg when the leg is flexed, or they're going to have their hips move when they bring their neck forward. Diagnostic tests are going to be CT and lumbar puncture. Medical management, they're going to give antibiotics, corticosteroids, anticonvulsants. Your nursing interventions, respiratory isolation is required. You want to keep the room darkened and noise to a minimum, and they can also receive the pneumococcal vaccine. The West Nile virus. So this infection occurs through the bite of an infected female mosquito. The patient will develop flu-like symptoms. The diagnosis is done by testing blood or cerebrospinal fluid. It cannot be transmitted through casual contact, such as touching or kissing. And you want to apply insect repellent to reduce the risk of being infected, and choose one that contains DEET, which is DEET. Next, we have our head injury. This is usually caused from motor vehicles, recreational activities, or sports. Injuries to the brain can result from direct or indirect trauma to the head. Direct trauma occurs when the head is directly injured. Indirect trauma results in an acceleration, deceleration injury with rotation of the skull and its contents. So your clinical manifestations, head injuries may be opened or closed. Open head injuries result from skull fractures or penetrating wounds. Your closed head injuries include concussions, contusions, and lacerations. A subdural hematoma forms as venous blood collects below the dura. The clot causes pressure on the brain surface and displaces brain tissue. So if a patient who has been conscious for several days after a head injury loses consciousness or develops neurologic signs and symptoms, you can suspect that it's a subdural hematoma. So that's going to be a blood clot in the dura. So you want to assess periorbital edema and ecchymosis, that's known as raccoon eyes. You have battle sign, which is a small hemorrhage spot behind the ear, which usually indicates fracture of a bone of the lower skull. A halo or ring sign is a little dot of blood seen on the pillow, which indicates spinal fluid is leaking. Diagnostics, they can do a CT, MRI, or a PET scan. Medical management, you want to give oxygen. Suctioning may be necessary, but never through the nose because of the possibility of a skull fracture. Medication used to reduce cerebral edema and increase ICP are mannitol and your dexamethasone. You can give codeine or other analgesics and anticonvulsants. Nursing interventions. So check the ears and nose carefully for signs of blood and serious drainage, which indicate that the meninges are torn and spinal fluid is escaping. Do not attempt to clean out the orifice. So if there is evidence of drainage from the nose, the patient should not cough, sneeze, or blow the nose. If cerebral spinal fluid is suspected, a glucose test strip will show a positive reaction for glucose. And you want to monitor the level of consciousness. Okay, our last disorder here is the spinal cord trauma. This is complete cord injury, which is all voluntary movement below the level of trauma is lost. You can become tetraplegic, formerly referred to as quadriplegic. And those who sustain injuries to one side of the cervical segments of the spinal cord. You have paraplegic patients, are those whose lesions are confined to the thoracic, lumbar, or sacral segments of the spinal cord. So one of the major clinical manifestations is autonomic dysreflexia. This is called hyperreflexia. It is a neurologic condition characterized by increased reflex actions. It occurs in patients with cord injuries at the 6th thoracic vertebra or higher, and most commonly in patients with cervical injuries. It is an abnormal cardiovascular response to stimulation of the sympathetic division of the ANS, and the condition occurs as a result of stimulation of the bladder, large intestine, or other visceral organs. So the clinical signs of this is bradycardia, hypertension. So their systolic pressure can be up to 300. Diaphoresis, goose flesh, flushing, dilated pupils, blurred vision, restlessness, nausea, severe headache, and nasal stiffness. The most common causes of this condition include a distended bladder or a fecal impaction. So that's why it's so important for you to monitor their bowel movements. If they haven't gone after 2 to 3 days, you need to intervene. You want to assess for pain, level of consciousness, level of alertness, their bowel and bladder status. They can do CT, MRI, spinal tap, or myelogram test. Medical management is immobilization through skeletal traction. They have what's called Crutchfield tongs that can be inserted into the skull to help keep it in place. You can give steroids. Nursing interventions, unless contraindicated, you want to place the patient in a sitting position to decrease BP. So if this person is having the autonomic dysreflexia, you want them to be in a sitting position. Okay, you can check patency of catheter for kinking. So if catheter is occluded, insert a new catheter immediately. And you want to check the rectum for impaction. You want to maintain alignment and encourage fluids of 3,000 to 4,000 milliliters a day unless contraindicated. Okay, so that concludes all 3 parts of the neurologic system. Thank you for watching. Give me a thumbs up if you find these videos helpful. If you have any comments, leave it below, and thank you for watching.